Hi, this is Piyush Bhargava and I have an interesting case to share with you. So this patient underwent an FDG PET CT scan and we have the whole body rotating image and anterior projection on the left showing uptake in the gallbladder. This is localized better on the fused transaxial PET CT image seen here, and we see the gallbladder here on the CT image. Now this uptake is inside the gallbladder. It's in the lumen of the gallbladder. When there is linear uptake in the gallbladder wall, that is considered suspicious for acute cholecystitis. This patient underwent a follow-up right upper quadrant ultrasound, and I have an image here showing normal appearance of the gallbladder. There are no shadowing stones. The gallbladder wall appears normal. There is no pericholecystic fluid, and this patient did not have any tenderness. So the ultrasound of the gallbladder was normal. So what is the cause of this uptake of FDG inside the gallbladder lumen? This is something that happens very infrequently, but it has been reported. And here in this paper, the authors are suggesting that this may be due to FDG excretion into the bile. Now, what is the molecular mechanism and why this happens is not known, but infrequently we can see excretion of FDG from the liver into the gallbladder, but this is different from uptake in the gallbladder wall, which is considered suspicious for acute or chronic cholecystitis depending on the clinical situation. So this case is interesting because it shows excretion of FDG from liver into the gallbladder. I have another companion case of another gallbladder pathology. This patient underwent a CT scan, and on the SCOUT image we see this linear calcification of the gallbladder wall, and on the coronal image you can see here this is the gallbladder and there is linear calcification in the gallbladder wall. Gallbladder wall calcification is frequently seen incidentally on CT scans. This finding is called porcelain gallbladder. This is when there is calcification of the gallbladder wall. Typically it's more common in females in the 6th decade of life, and it's due to chronic inflammation secondary to gallstones. If you do an ultrasound in this patient, the calcifications can be mistaken for gallstones because of the shadowing, and when we do a HIDA scan with CCK, we can find low ejection fraction in these patients. Cholecystectomy is typically recommended because of the association of porcelain gallbladder with gallbladder adenocarcinoma. Here's a paper describing the uncommon gallbladder conditions in some unusual presentations. So 2 interesting cases. Thanks for watching.